All clinicians on some level treat pain. Whether you're an anesthesiologist, emergency medicine physician, or interventional pain specialist, there's something for everyone to learn at one of our ultrasound courses. Our curriculum covers basic techniques for the beginner and more advanced techniques for the experienced sonographer. We ensure that those who treat pain have the tools required to take care of the most basic problems as well as perform the more advanced procedures, such as peripheral neuromodulation and the injection of biologic agents such as PRP or bone marrow aspirate into the targeted tissues. Our courses are open to all clinicians. We offer CME credit. We plan to do courses abroad as well as in the United States in the coming year, and we hope to see you there. For more information, go to painexam.com/events or internationalpainacademy.org. Hi, and welcome back. This is a podcast slash webinar webcast with our sponsor, Rachel Trobman of Upside Health. Rachel's a digital executive health expert and leader in remote care space. Her company, Upside Health, is dedicated to transforming pain care and has helped clinicians, health systems, and tens of thousands of patients through their product Branch Health. She's actively involved in legislation surrounding remote billing codes and collaborates with the AMA, CMS, and leading law firms. Before I hand it over to Rachel, I just wanted to remind you all that we have a whole slew of courses coming up. Just check the Pain Exam events page. We have ultrasound courses and another board review course coming up and much, much more. Rachel, welcome to the show.
Hi, thank you. It's great to see you again. Can I become host so I can share my screen?
I will most definitely make you host. And some of you may remember Rachel. She was on the podcast before, and we did a webinar in which she really was giving us a lot of vital information, and she did some updates to that information, and that's what prompted this webinar slash podcast. Take it away, Rachel.
Yes, thank you, David. I think one of oh boy. Let's try this again. Great. So one of the things that prompted my return was the discovery in the new physician fee schedule that came out in July, or the proposed physician fee schedule that came out in July, that had a lot of changes, most of them good, to digital care, remote care. And additionally, there was the creation of these new chronic pain management codes. And when I was speaking with David, it was a surprise to you and to many colleagues. And so I thought it might be a great opportunity to introduce where we are now, what could change, and what your community can really do about it. As a quick reminder, this is not any sort of legal advice and is not a guarantee of reimbursement, but more educational in nature. So just in terms of what I'm going to be chatting about today, one is the high level changes, and then a little bit of background for those of you who weren't in any of the previous sessions or those who do, but it was a lot of heavy nonsense that I was throwing at you. And then a few details about what we know now and what we don't know about January's new codes. And then again, like what's next. A bit of alphabet soup here. There's a lot of terminology that I'm going to be talking about that you may know about or you may not. And I thought it may be a good opportunity to share some of this right now. So RPM is remote physiologic monitoring. The P stands for physiologic, not patient monitoring, which is like the generic term. Physiologic monitoring involves a physiologic metric. Think heart rate, blood pressure, pulse ox, weight. Those are all concrete measurements that have to be delivered through a medical device. RTM, remote therapeutic monitoring. That is monitoring of treatment, medication, pain score, really anything related. It can be patient reported, but it has to be from a medical device. CCM is chronic care management, a slew of codes that was released by CMS to allow for the additional support of complicated patients. And then BH, for the sake of this conversation, we're referring to behavioral health codes, of which there were a bunch that were added in this new proposed fee schedule. The big takeaway from this release is that CMS is continuing to invest in care management, remote care, and monitoring. Unlike other codes, instead of clawing back, they made clarifications and added new ones. And a lot of this came from feedback from clinicians, from digital health executives, saying that this is what we need for these programs to be successful. One of them is RTM codes, as we knew and loved them, or didn't, don't exist anymore the way that we knew them, throwing a nice wrench into many people's plans in that they exist, but now they have new numbers. and before, they used to just be for two indications, musculoskeletal and respiratory. They've now added behavioral health as a new bucket of RTM codes. Additionally, they've allowed them to be executed under general supervision. They were currently allowed under general supervision under COVID emergency changes, but this is going to be officially documented. They can be offered under general supervision like RPM.
Do you have any idea what that would entail? I mean, if a patient of mine is anxious, so then I would be monitoring their behavioral symptoms. I mean, their anxiety or this.
Yeah, so it's just any sort of validated screening tool that is capturing this information. So any software as a medical device, you can monitor changes in mood through any sort of validated screeners. You can monitor medication usage and treatment efficacy and how that's changed any sort of functional metric.
Mm-hmm.
And the other change that is related to these codes is that they've kept the 16-day minimum number of data points for RPM. Continues to be pushback on that from many because in some cases it's contraindicated to have, every other day checking something like this.
Right.
And then for this audience and for myself as, company owner in this space, the new chronic pain management codes are an exciting addition to this offering. And I'm going to dive into more about that in a bit. But first, I have to provide a little context as to how we got here. And it's pretty much every year for the past 8 years or so, every year CMS has been adding new chronic care codes or remote care codes. As I mentioned, like diving deeper into their commitment into this space. And in many cases, they'll test something, pull it back, test something, cut the fees. In this case, they've been adding more and more. So more use cases, more extension codes, more variability, and actually in many cases, now that they have the data, increasing reimbursement. They probably will eventually, in all cases, start pulling back, contracting on these things. But there's very good data right now that indicates, one, patients really like it. Two, it's actually impacted outcomes and reduced hospitalization and ER visits. And so for that reason, obviously, from a payer mentality, it's a successful program.
Are those in studies from pain management patients or other specialties like cardiology or something like that?
Who like it?
No, in terms of the data showing that there's less admissions to the hospital and that better outcomes. Is it in the pain world or is that general?
So it is general, used, in cardiac cases and respiratory cases. There was a lot of COVID right now because obviously telehealth and RTM and RPM really picked up in the world of COVID with all sorts of healthcare systems launching what they call hospital at home programs. So sending patients home with a pulse ox, for instance, and monitoring it and calling them and moving them in only when necessary. As RTM, RPM, a little bit newer in the pain space, but they have seen impact with BHI and all sorts of collaborative care models and the impact when it comes to pain. The other big note in the 2022 fee schedule was about 20 pages or something crazy dedicated to chronic pain management, talking about the problem, the existing challenges with pain care in the US, the crisis many clinicians are facing in terms of managing these patients, but there was no action there. It was just addressing what many people on this call know is a problem and then just leaving it that. And we saw why in this physician fee schedule, and I'm going to dive into that a little bit. But the big takeaways from this are, or from the previous things, are what RPM and what RTM is. And this is important because in the case of chronic care management and BHI, you see a lot of add-ons. So you can bill or you can implement solutions for RPM and BHI. You can solutions for RTM and CCM. So understanding how these things are different makes more sense as to why these services are often bundled. So the similarities for RPM and RTM needs to be medically beneficial and necessary. There needs to be patient consent. Actually, it can be written or I believe verbal as well. The data needs to be actually captured somewhere. And there needs to be a patient interaction. It can be virtual, it can be through the phone, but there needs to be some review over the data that's collected. And then that data needs to be reviewed. Somebody has to see this data. And I mean, I like to say that it must be easy to use, or it doesn't make sense to roll out a program like this. And the big difference is who can order or enroll patients in RPM versus RTM, the minimum day capture requirement, how the data can be captured. So in the case of RPM, it has to come from a physiologic metric or monitor. In the case of RTM, it can be patient reported, but has to be through a medical device. It can be software as a medical device. And then who can review the data? Right? What are the requirements?
Do you find that most physicians who get on board with this, I assume this is mainly a Medicare program. Are you seeing this with the commercial payers as well?
No, I mean, but commercial payers. So Medicaid is varying from state to state. California, I have like a whole list. I'm happy to share afterwards in terms of like what states are Medicaid. Medicare is covered. Commercial payers, I think we're looking at like 80%. I mean, states where there's parity, payment parity, it's of course covered by commercial. And then we've seen pretty substantial commercial coverage in New York, New Jersey, DC. I mean, places where we're operating
right
now.
I have a colleague who's a pain physician, and he basically uses this mainly for his opiate patients. And he doesn't use it across the board, but he finds that with that level of care, where there's something every month and there's theoretically a risk of changes to their vitals or any other sort of, I guess, side effect, he found it very useful.
Yeah, I mean, I think in terms of documentation too, just really having documentation as to what patients have been doing on their own, noticing any, small or large changes. And then in the case of like BHI or CCM, there's normally some sort of care management component too. So whether it's introducing educational materials or whatnot, it tends to be successful in that capacity. And we've even seen, like, talking about like outcome metrics, like we've seen more successful tapers on our platform.
Wow.
Because there's somebody else holding the patient's hand,
right?
And they need it a little bit more.
Sure.
Than a 15.
The withdrawal could trigger some sort of, the vitals will change, and you can notice the blood pressure is increasing. So
Yep.
Makes sense.
So now in terms of what we know for these new codes and what we don't. So really focusing specifically right now on these chronic pain management codes. So we know that there are going to be 2 new codes and there are going to be G codes. We believe that they will be likely similar to CCM codes, and I'll outline why in the next slide. As of right now, they can only be ordered by a physician or qualified healthcare professional, so they're not incident to. They're supposed to be comprehensive. So you'll see there's multiple components that are included in this, in these codes, and they can actually be used by primary and specialty care providers at the same time. So if a physician is being treated by a primary care clinician for pain, and then they are referred to a specialty care physician for pain, both are offering chronic pain management services. You as a pain doctor are very well aware of like the multimodal nature of pain care. You have a lot of tools. What CMS was seeing and what they like refer to actually specifically in their language is how primary care doctors often are 25% of their patients are, chronic pain patients, and it requires a ton more work to help manage these patients, and there's no compensation for that. So these codes, these G codes, they called out these various components as part of what's included in chronic pain management. So it's bundled care in a way, just like the other CCM codes or the BHI codes. So this dealing with chronic pain care should include some sort of diagnosis, monitoring using validated pain rail skating or tools, patient-centered care plan, including goals, strengths, clinical needs and outcomes, treatment management and medication management, the facilitation of BHI or BH if necessary, facilitation of PT, OT, and community-based care if necessary, pain education care, pain crisis care, and care coordination. It's a lot of things.
I'm trying to understand something.
Yes.
So you have monitoring in here. So I get that you monitor their blood pressure, heart rate, or SAT, or no? Are we talking about their pain level, or are we talking about?
Right. So
because I'm already doing like most of this stuff on my regular follow-ups with telehealth.
Right.
So
but you're not billing for the complex nature of the pain, are you?
Well, I could bill. No. Now the way we code it is we tell our billing company the time we spent on the line, and then they translate that into some sort of code, I guess. But I'm just wondering how this differs from the current of what we're doing if we're not talking about actually monitoring with their physiological parameters, et cetera.
Well, so this is where there's a lot of question marks.
Okay.
This is what we're trying to figure out, because this is it. In the case, it's showing that in order from what we were gauging in conversations with CMS and people who have added these codes, is their intent is to make sure that all of these, one is to recognize that many physicians are doing all of these things already, or some of them, and that it's time intensive on top of everything else that you're doing.
Okay.
Second is to make sure that it is robust and comprehensive in what is being offered. The big question mark is really, how is this being monitored? What is going to be the documentation? Can this be, is it supposed to be like a hodgepodge of different things? Like, are you documenting in one place and then you're proving that you're monitoring something else? And there's a lot of questions as to how in actuality it's going to be rolled out. But in the case of like not as a sales thing at all, but in the case of like extensive complementary care platforms like ours, or that exist right now in CCM, right? There are services that do all of this in a documented way. So they have tracking, screening tools, BHI, care coordination. It's like a care coordination extension where they wrap everything in a bow. And this is happening in addition to, not instead of, in addition to the care that's being provided.
So let's say hypothetically, I'm doing the remote patient monitoring. So that's something that we set up, and then we can outsource the review, correct? And then like a company like yours, for instance, would help us process that data.
Mm-hmm.
And this is a completely different.
Add-on, exactly, it's add-on. So you would
This
run,
is down.
correct.
Right.
So
Because I wouldn't want some third party processing all this. This is something I need to do, or at least my staff, a PA or somebody, because this is like really what we normally do. This is making a treatment plan.
maybe,
It
but
says treatment management.
no, I mean, but this is so, but there, it might be comprehensive. So some of it might be what you do. Some of it might be you outsource to other people.
Okay.
Some of it may be a combination. And then there's other places that don't have, like, think in the primary care environment, they may do the diagnosis, right? You're not going to outsource the diagnosis, but you're going to need support with potentially the monitoring, the medication management. Like there may be components in order for this to be successful that are
Right.
going to have to be collaborative. They're going to have to be team-based.
To me, this all makes sense, like how they're trying to do more remote this or that and everything. But I'm also thinking CMS. So as much as they're maybe spending more on it now, they're trying to save money at some point.
Of course.
The question is, I understand keeping people at home, so you're not spending money on the transportation, or maybe if you keep the pain patient out of the pain doctor's office, then they're not getting that extra trigger point or that extra injection that's going to cost more money in the long term. It might be actually cheaper in the long term because you're getting them off meds or this or that, but I'm just trying to be a little cynical about what CMS is doing, because I'm sure that their endpoint is to save money, which I understand.
Mhm.
But I'm also trying to think, are they trying to keep more of these pain patients with the primary care docs?
Well, but the truth is that so many pain patients are already with their primary care doctor,
Correct.
right? So I think I mean, truthfully, they're less concerned about when the patients already get to specialty care. These
Okay.
codes, all of these codes were primarily focused initially around primary care and keeping the patients that were being undertreated or incorrectly treated or incorrectly diagnosed, patients who couldn't, wouldn't, or for other reasons, like could not make it to a pain specialist, right? So either there's not one in their area, it's not covered by their insurance, they don't want to, like,
Right.
but so they're going to continue to go to their primary care doctor, and their primary care doctor is like, I limited in what they can actually do, but spend a ton of time and resources on these patients.
Okay.
And so that's really where the I think CMS is very concerned, in the long run, is health equity, and somewhat meeting patients where they're already at. So if they're already at primary care and they have this pain condition, right? Like, how do they bridge that gap?
Actually, listen, on the flip side, this actually may trigger more referrals. I don't know. We have
Well,
to see
and
how it plays out.
that's the thing too. Although, really from what there's also that question of like increasing potential volume in pain clinics, because if the providers are being reimbursed and supported in the components of care that aren't, like, you could be doing more procedures or injections that you're super specialized in that nobody else can do, that could increase your bandwidth so that all the other care components can be managed effectively, and support. In terms of what's next, or like why even are we having this conversation when there's so many question marks? Well, CMS opens up a public comment period for 60 days between July 7th and I believe the end of September, or middle of September, whatever 60 days is. I guess it's the beginning of September, in which they must read every public comment. And there have been, but there have been real changes. So that general supervision for RTM versus whatever I was saying before, I've lost my train of thought. That came as a result of public comment. There was something else when RPM first came out, that through public comment, I think we were talking about the non-physiologic metrics. So like pain in some capacity, medication monitoring, how all of that could play an important role in care. And that's where the RTM codes came from. So there is something that, but if you, for instance, like, it doesn't all have to be positive. It can be negative. It can be positive. Like, but if it's something that anyone here is interested in, I work with a bunch of groups. I don't make any money off. Like, I work with a bunch of groups that do write these letters that clinicians, industry, whatever, can sign on to. They don't have to, you don't have to write them. You just sign on to it, and they have to acknowledge it. And that's heading into the November when they release the final physician fee schedule, at which point we can always touch base again in terms of what they mean and what the amounts are. But just as a quick, like, in terms of what we think the ranges for reimbursement are going to be, I'm leaning heavily on the chronic care and principal care management codes, since they seem very similar. And it's not replacing a visit. You're looking at we're looking at, for a clinician ordering and like managing the services, about $140 per patient per month. And from if you're like a support care is doing it.
Visits in that month, though, I mean, 60 measurements in that month. Is that what
So
you?
this is so no. So you're still on RPM. I'm
Right.
talking about.
I know, sorry.
It's okay.
I get you. I know where you are now, but yes.
Yeah, I don't know. No, this is on the chronic pain management codes.
Okay.
I'm just following whatever the PCM is. And then on the low end, $110, $15. But as I mentioned, right, they're bundling. You can bundle them with the other codes. Again, this is still TBD. Stay tuned.
Right.
And would love to answer any questions that I might be able to help with if we have a few minutes. Otherwise, happy to
We
talk offline.
definitely have a few minutes. If anyone has any questions, just type them in the Q&A box. So I have a question. So where do you just see the future? What do you see 5-10 years from now? Like, what's going to be the standards of healthcare? What do you think will be?
Good question. I mean, I think that obviously I built a business around this. I think that digital health plays a really important part in care in terms of equity, in terms of access, but I don't think it's a replacement of care. I think it's going to help better triage care. I think it's going to help better direct patients to where they need to be at the time they need to be, and optimize clinician time for the things that they're most trained at. I think that I think there's going to be consolidation. I don't think you're going to see 20 million products doing the same thing. I think there's going to be more platform plays. So hire this suite of products that does different things, or Next Gen or Advanced MD is going to have a suite of offerings of products they've acquired. I mean, I think that's more of what I see, but I think that it's going to play an important role.
This all sounds realistic. We have a few questions here. Can you see them from your end?
Yes. So do you bill these codes in addition to outpatient E&M codes? Yes. So these are monthly codes that are billed as extension of services. And the same thing with, yes. So you don't actually bill them typically on the same day. They could be billed on the same day, but it's whatever day the service is rendered. So we tend to, so for instance, like, we wait for it has to be at the month. So the end of the month, we tend to reflect or put the notes together and bill them. For like the super specifics on our billing protocol, I'm happy to get for you. We have like a team that says like when things can be billed and at what time. But I know that, for instance, with one of our clients who's in Athena, we attach the order, they attach the billing to an order or to an encounter rather. But it's it has different codes associated with it. How often do you contact the patient each month? Good question. So in our capacity, we have at least one encounter with the patient per month. Well, through a registered nurse. Our team of patient engagement people and whatnot are interacting with the patients a lot more regularly than that, but a clinical call happens once per calendar month. But then normally when we onboard a practice, we work with them to develop a triage plan. So if then, for almost each use case, so if our nurses identify something of X, Y, or Z, how would you want to be notified? Do we create an appointment for them in the EHR? Do we page the office? Do we call? We have to develop that. So that way we're still operating under their care. Would heart rate measurement count for RPM, RTM? So as of right now, so Garmin, Withings have a few FDA medical devices, but any sort of wellness device like an Apple Watch, unless it's used with cardia, are not medical devices. And so you can't, by our reading, we don't think that qualifies as RPM and RTM. I'm happy to get into pricing offline. It's really much, it's like a fixed per patient per month fee.
And if I was interested after this webinar in getting in touch with you, how can I reach you?
Oh, just keep on banging down David Rosenblum's door until you get in touch. It would be, it's Rachel at upside.health. And if you were registered for today's session, someone from our team will likely be reaching out. No pressure, but we can answer questions in regards to rates and opportunities. And really just, above all, I want to be a reference to help navigate this world of digital health codes. So please, even if it's like not related to me, if it's related to a competitor, if it's related to understanding the industry better, please connect with me on LinkedIn or shoot me an email, and I'm happy to help troubleshoot with you, because it's really, right now, every practice runs so differently. I don't think like a one size fits all approach is going to win here.
And your company is Upside Health. So
Yeah.
it's pretty easy to find. Just
Google upside.health.
Excuse me, upside.health.
But thank you so much for having me again, David.
My pleasure. Thanks for coming on, and thanks for sponsoring. We have one more question. When do the codes go live?
So many of the codes that we discussed already tonight are live. The chronic pain management codes will take effect January 2023 by Medicare. And then normally commercial insurance follows, unless it's a case of parity in the state, in which case they take effect at the same time.
I truly think this is the future. Well, it definitely is. I mean, it's just really how it's going to shape itself, and how quickly we're going to adopt. But I want to thank you again for coming on the show. I'm going to have Rachel's contact information and link to her website and email in the show notes. And once again, thanks for joining us. I look forward to seeing you at the courses or online. Take care, and thank you again.
Thanks a lot, everyone. Have a great evening.